be talking about how we use DBT to treat substance use disorders in our dual diagnosis program, and how DBT has been utilized to treat more than just borderline personality disorder, which is the original aim of the treatment. So as I just mentioned, DBT was originally developed for the treatment of borderline personality disorder, and it's still considered the gold standard treatment for BPD. But since the development of DBT, it's also been studied for the treatment of eating disorders, substance abuse disorders, suicidal ideation and attempts, depression, bipolar disorder, PTSD, and ADHD. The interesting part is that what all of those have in common is that, at least according to the DBT theory, the underlying biosocial theory, is that people that suffer from these conditions also suffer from chronic emotion dysregulation. So what's great about what we're able to do in our dual diagnosis program is we get people who are coming in for residential substance abuse treatment who most often have co-occurring mental health diagnoses like depression, anxiety, PTSD, personality disorders like borderline personality disorder. And we're able to treat both at the same time because of the DBT framework. So what we use is sort of like the old self-medication model of substance use, where we're looking at the connection between how substances are used to treat the underlying emotion dysregulation. Most of our clients struggle with more than 2 or 3 of the disorders listed in this list. So many of our clients will have BPD plus an eating disorder, or eating disorder behaviors plus substance abuse, and depression, anxiety, potentially PTSD, all of those happening at once. So rather than taking a sequential approach with DBT, what we're able to do is look at the underlying chronic emotion dysregulation and treat the behaviors that stem from that emotion dysregulation using the DBT framework. So I'm going to be talking about the DBT framework. Some of this may be a repeat from previous speakers in the series, but I just want to give an overview for people who haven't heard the rest of the series, and then we'll talk a little bit more specifically about how we use the DBT adaptations for substance use disorders to specifically deal with those issues. I just want to mention also that if you have questions, please feel free to write them up in the chat box, and I will answer those questions at the end. And I will give an opportunity for people to ask questions at that time. But as things come up throughout, feel free to put them into the chat box. Okay, so when we're talking about DBT, one of the important things to take into account is the underlying theory of why people struggle with the issues that they struggle with. And in DBT, what we use is called the Biosocial model of chronic emotion dysregulation. That model posits that people who end up having this pervasive emotion dysregulation are both born with a biological dysfunction in their emotion regulation system, so that's the bio part, and then socially they experience an invalidating environment during their upbringing. So those two things together lead to a chronic inability to regulate emotions. The biological part is a combination of both emotion dysregulation and emotional vulnerability, which leads to an inability to modulate emotions. What this basically is saying is that people who end up having these psychiatric disorders related to emotion dysregulation are often born with a more sensitive emotion regulation system. So they tend to be more emotionally dysregulated and are more emotionally vulnerable in the sense that family members will often say, you know, this person was this way since they were a kid. They've always just been more sensitive than other kids, or than their sibling, or than, you know, than we as parents or whatever. So that's just the person's born disposition. This is what the emotional vulnerability looks like. People with this biological emotional vulnerability have high sensitivity. So they have more immediate reactions to emotional stimuli. And they also have a lower threshold for emotional reaction. So something that might not elicit an emotional reaction in the average person may actually elicit a strong emotional reaction. High reactivity, meaning that the reaction itself is usually more extreme, and that the level of arousal dysregulates cognitive processing more than it would in the average person. What this is talking about is that people with chronic emotion dysregulation tend to get more dysregulated. And when anybody gets really dysregulated, their cognitive processing tends to go offline. And so they're not able to make more logical decisions, plan long-term and things like that. And so a more benign stimulus may actually make a person who has this chronic emotion dysregulation have their cognitive processing go offline, which leads to impulsive behaviors and things like that. And then finally, these people often have a slow return to baseline, meaning that their reactions are more long lasting and they contribute to a high sensitivity to the next emotional stimulus. So in the next slide, I'm gonna talk a little bit about what that would look like, sort of go through an example. So the top line in red would be the target population. So pretty much anybody who struggles with emotion regulation. And for the sake of this talk, we're talking about people who have borderline personality disorder, substance use disorders, anything in which regulating emotions is at the core. And then at the bottom in the blue are controls, meaning the average person. So the example that I like to give is just like an average work day for myself or anybody else. So if we start at the bottom at time 0, a person wakes up in the morning, and we'll just follow along in the blue line, gets in the car and hits some traffic. And time 5 is, let's say, a meeting that the person needs to get to, and they realize that they're going to be late for the meeting. So the average person, their subjective units of distress, what we call SUDS in our program, meaning just how upset or dysregulated they're getting. This person's shooting up to about a 3. They call their office, let them know that they're going to be late. The person on the other end is fine and understanding. They get to work. They're about 15 minutes late for the meeting. Go on with their day. Now we're at time 12, and the same person gets a text message from his or her boss saying, I need to see you in my office. Get a little spike of anxiety up to like a 2, and then go to see the boss. Boss just says, hey, I have a new project for you. Come back down to baseline, go on with the day. The person in red having the same experience, so we're back at time 0. The person's woken up at the same SUDS level. But when the same thing happens, the traffic jam, the person shoots all the way up to a 7, right? Because their emotional sensitivity is just that. They're more emotionally vulnerable. And they're having a harder time coming down to baseline. So when we're at time 5, 6, 7, 8, 9, and 10, they're still up at a pretty high level of distress. And they're probably during this time pretty frantically trying to make their distress go down, but being unable to. So when we finally get to time point 12 and the boss texts this person, they're already at a 7. And so they're going to shoot all the way up to a 9 or a 10 in the situation. So this is a situation in which we're seeing the same sort of environmental stimuli, but because of the emotion dysregulation that happens to people whose system is sort of running overtime, their emotional experience is quite different, and their reaction will be quite different. So once somebody is at around a 7, 8, 9, or 10, their cognitive processing is going to go offline, meaning they're more likely to make impulsive decisions, not be able to take the long-term repercussions of their behaviors into account, and be more desperate to make their level of discomfort decrease. So we talk about this diagram so that we can help family members and clients themselves understand why certain behaviors may come up in a situation in which the average person may not react similarly, but we can actually validate the person's experience because their emotional experience really was subjectively that much more intense than the average person. So the social part of the biosocial theory is the invalidating environment. Invalidating environments can vary. So it can be as simple as just behaviors and communications being rejected as invalid directly, or it could also be indirect. So more straightforward things would be like a parent telling a child to stop feeling that way. You shouldn't feel that way, or, nobody else feels sad when their friend leaves their school or something. But more indirect ways would be like oversimplifying problem solving. So a child may say, I'm having a hard day, and parents will say, well, shake it off, right? Or get on with your day. Those kinds of things can also on an ongoing basis create an invalidating environment. There are also a lot of sort of social factors involved. So bullying in schools can be part of an invalidating environment. Sometimes a person's own sexual or gender identity, even if it's kept private, can be invalidating in the sense that it's something that they keep secret and aren't able to share with other people and feel like what's communicated to them is that something about them is wrong. So often in these situations, we're talking about people who have already sort of overactive emotional systems. Their emotional displays are met by punishment. And when they escalate, it's often met either with ignoring or sometimes with reinforcement. So the example I like to give is a kid who freaks out in the grocery store because he or she isn't getting the cereal that they like. The parent ignores it, feels like they're trying to extinguish the behavior until it gets to a point where it's escalated so high that they just give in and give the child the cereal. That would reinforce that behavior. Oftentimes as parents, we don't intentionally do that, but trying to just survive parenthood, we end up unintentionally invalidating our children's emotional experiences. And when somebody has that biological predisposition, the invalidating environment sort of takes it over the edge and creates this sort of pervasive emotion dysregulation problem. So some of the consequences of chronic invalidation are that the environment fails to teach the individual to effectively label their private experiences, which then leads to a difficulty effectively regulating emotions and trusting experiences as valid responses to events. So oftentimes our clients don't feel like they have a gut instinct. Their gut instinct has been communicated to them to be not working correctly. So instead, the environment teaches them to self-invalidate and search the environment for cues about how to respond. So oftentimes our clients will rely on others to help them make decisions, or otherwise will make decisions quite impulsively because they don't know how to trust their internal experience in order to guide their behavior. So let's shift gears a little bit and talk about what DBT is. So that's sort of the target population and what we believe is underlying in the target population. Now we're going to move on to talk about what the treatment is. So DBT is a cognitive behavioral treatment. It was developed by Marsha Linehan in Washington. And it emphasizes 4 parts actually. So individual therapy as well as group skills training classes. And there is also phone coaching available to clients, which I'll get a little bit more into, and a consultation team for the therapists. So the core skills of DBT are mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. And so DBT was originally developed to treat chronically suicidal individuals who ended up being diagnosed with BPD. So Dr. Linehan was treating mostly women in the Washington hospitals who were chronically hospitalized, most of them drug addicted, in and out of the hospital for suicide attempts. And in order to get funding, she ended up finding that BPD was the best diagnostic category. And so eventually, as it continued being studied, it became the gold standard treatment for BPD and now for other populations as well. So in the late 70s, Dr. Linehan was initially trained in standard cognitive behavioral therapy, where the clinician basically meets with the person and helps them look at their thought patterns and their behaviors and to change their thought patterns and behaviors. And what she found was that the people that were receiving CBT, who also had this underlying emotion dysregulation problem, found that CBT alone, with its unrelenting focus on change, was incredibly invalidating. And that invalidation led to increased dysregulation, which made people drop out of treatment, became angry, or would sort of vacillate between the two. Try to attend treatment, but then become angry and leave, then come back. So this resulted in a high dropout rate. The other part of it was that many of these people had so many problems and so many severe problems that needed to be addressed rather quickly that the standard CBT format was just too sequential to handle all of the problems at once. So what Dr. Linehan did was she added validation and dialectics. These were concepts that she brought in from both Zen Buddhism and from dialectical philosophy. So This is where the acceptance-based interventions were added. And so one of the primary dialectics in DBT is acceptance versus change. And so all of the change stuff is around the cognitive therapy piece. And then when we talk about acceptance, we talk about things like validation, and looking at what is already sort of working for people. So adding this communicated to clients that they were both acceptable as they were, and that their behaviors, including those that were self-harming, made real sense in some way. And therapists learned to highlight for clients when their thoughts, feelings, and behaviors were perfectly normal, helping them discover that they actually had sound judgment and they were capable of learning how and when to trust themselves. So DBT provides us with many protocols in how to look at client behaviors and how to treat clients. So one of the problems that was identified early on by Dr. Linehan was that there was a high level of burnout for clinicians in working with this population. One of the reasons was because of just the sheer number of issues that needed to be prioritized. The other part was that clients had fluctuating levels of motivation. So she provided us with a list of assumptions about the patient to help us guide our work, and to sort of keep in mind the client's perspective. So the assumptions are the following: patients are doing the best they can, patients want to improve, and then this is sort of the other side of the dialectic: patients need to do better, try harder, and be more motivated. So those first three are really important, because we need to always keep in mind that people are doing the best they can. So when behaviors are frustrating, upsetting, and feel targeted toward others, we remind ourselves that people are doing actually the best they can given the skill set that they have at the moment. And at the same time, that doesn't mean that we don't push our clients to do better, try harder, and be more motivated. Patients may not have caused all their own problems, but they have to solve them anyway. The lives of suicidal borderline individuals are unbearable as they are currently being lived. Patients must learn new behaviors in all relevant contexts, and patients cannot fail in DBT. So we say patients cannot fail in DBT, therapists can fail at DBT. So once a person is doing DBT, the onus really becomes on the therapist to help the client maintain motivation, to troubleshoot problems in therapy, to address therapy interfering behaviors. So we make the assumption that patients cannot fail. They may not be able to complete a treatment. They may take time off from treatment, but they cannot fail at it. They can always come back and try it again. So like I said earlier, there's a standard protocol for DBT, the way that it's been studied in numerous randomized controlled studies. One outpatient individual session per week. There's an outpatient skills training class. Again, it's a group setting, most often once a week. Phone coaching available between sessions to help clients generalize skills, where they can call their therapist for skills coaching in the moment, in a moment of distress. Consultation team, which is what we call sort of therapy for the therapists. And then ancillary treatments like pharmacotherapy. Most of our clients are on some kind of medication. And then acute inpatient psychiatric. So our clients are most often suicidal when they come to us, and inpatient psychiatric holds are pretty common experiences for them. As part of the DBT framework, we try as much as possible to reduce the need for inpatient hospitalization. It's an assumption of DBT that in general, hospitalizations are not helpful. In the long run, they often actually place a person at higher risk for reattempt of suicide. So we try our best in a program like ours to keep people safe within the confines of our program. So we do a lot of safety planning and a lot of monitoring, and sort of use inpatient psychiatric hospitalization as a last resort. So DBT is broken up into 4 stages. Stage 1 is sort of the most well-known. It's the introductory stage. It's where people's goal is to go from severe behavioral discontrol to behavioral control. So during this stage, really the focus is on changing behavioral patterns. And why this is important to substance use is that for us in our dual program, where we're using DBT for substance use disorders, what tends to be the primary target is substance abuse. Most often our clients also have co-occurring self-harm behaviors, suicidal ideation, eating disorder behaviors, potentially stealing, impulsive sex, all kinds of things. But what all of our clients have in common is that their primary target is substance use. And what we're trying to do through our program is to use the DBT skills to help get through the urge to use a substance to deal with a negative emotion. So that just happens to be the target, but the underlying process of emotion regulation that the substances provides is actually very similar across all of those target behaviors that I just mentioned. So what we're trying to do is decrease life-threatening behaviors first, then therapy interfering behaviors second, and then finally quality of life interfering behaviors. So for our clients in the dual program, life-threatening behaviors include active suicidal ideation as well as active self-harm. Those are the first things that we target from session to session. And then the second are therapy interfering behaviors. So many people come to our programs having had some treatment failures. And so what we want to do is, after addressing life-threatening behaviors, we want to make sure to address the behaviors that get in the way of the therapist or the client being able to complete treatment successfully. And then finally, the last is quality of life interfering behaviors. Chronic substance use actually falls under the third priority. But most often what we're doing is we're actually weaving all three together in any given session. And then we're wanting to increase the skills. One of the things that I think is important just to mention is that when we're talking about the DBT skills as they're applied to substance use, most often what we're seeing with clients who come to our program is that their emotion dysregulation is a prompting event for a substance craving. And so using the skills, particularly the distress tolerance skills in the beginning of treatment, is a really important way to get through the urges and cravings to use, because those cravings are often coming from a desire to decrease emotion dysregulation. Just to mention really quick while I'm on the topic, as far as appropriateness for our program, we don't require any particular diagnosis. What is most helpful is working with people who have some understanding or awareness that their substance use is related to their emotions. Once people get into the program, we sort of help understand better what exactly is going on. But sort of as a basic level, we just are looking for people who can say, yeah, well, I use because I feel blank, or I can't stop using because when I'm not using, I have this symptom. So that connection between the substance and some underlying emotional state or mental health symptom is a helpful way to sort of start the process, makes a person more likely to benefit from a program like ours. So DBT is made up of three core theories: behavioral science, dialectical philosophy, and Zen practice. So some of the behavioral principles that we use in DBT is we observe and describe behaviors without adding interpretations or making assumptions. We generate theory-based hypotheses about core problems and controlling variables. We test hypotheses, we apply interventions with fidelity, collect data and analyze results, generate and test new data-driven hypotheses, and maintain focus on behaviors and the contingencies mediating their continuation. So that's a lot of words that mostly just mean that using DBT, what we're really trying to focus on is how a person's behavior relates to the bigger picture. So oftentimes when we're talking about substance abuse, people will say, well, I just use because this is what I've always done. Or I just can't stop using because I'm an addict and I don't have self-control, right? What we want to do is sort of take a step back and look at it more closely to really understand what's happening. So an example would be when I experience an intense level of shame, I have strong urges to make that shame go away. When I try to make that shame go away using a substance, it makes the shame decrease in the short term, and then in the long term, it actually makes my life fall apart. So we want to understand how the behavior is actually related to the bigger picture. One of the ways that we do that is through chain analysis. Chain analysis is, sorry, one sec. Chain analysis is one of the primary ways in which we look at behaviors. So just go, there we go. Oops. Okay, there we go. So if we're looking at a chain analysis, whenever somebody comes in with a problem behavior, whether it's happened inside or outside of the program, we really want to understand what caused the behavior, what led up to the behavior, and then what the consequences were. So if we start on the very left of the screen, vulnerabilities are anything that make the problem behavior more likely to occur. These are things that can happen anywhere from a year to 15 minutes before the actual problem behavior. So it could be anything from lack of sleep, not taking meds, being sick, anything that you can sort of think of that would make you more likely to sort of be tipped over the edge. The problem behavior is anything that we're talking about that a person wants to decrease. So like I said, substance use, obviously, eating disorder behavior, unsafe sex, self-harm, lashing out, all kinds of things. And so then when we're working on a chain with a client, we want to sort of work backwards and look at what the prompting event was. And it could be anything, but we want to look for what happened sort of right before the problem behavior that set the wheels in motion, and then what led up to it. So an example would be, my mom came into the room and told me to clean up my room. My heart started beating. I had the thought that I hate her and I want to die. And I had a strong urge to cut myself. I walked to the bathroom. I said, screw this, I'm doing it. Got an object out of the medicine cabinet and cut myself. Consequence was that I felt some relief short term. And then in the long term, I felt increased shame. And I never actually solved the problem with my mom. That would be an example of sort of like a very quick and dirty chain. And then what we want to do on the other side is help clients problem solve. So looking backwards, we'll look at the chain. We'll try to sort of break the chain and say, okay, where in this chain could I have done something differently? So if we're looking at the chain example that I just gave, we might say, oh, well, when I had the thought, I hate her and I want to die, I could have used a DBT skill. So an example would be, I may have done a tip skill. So that would be changing the temperature of my body to decrease my level of anger and anxiety. So I might have taken a cold shower, and that may have decreased my urges to self-harm, hopefully getting in the way of the problem behavior and then changing the outcome. So the goal is to, over time, analyze behaviors and see where we can intervene with the DBT skills, which I'll be talking a little bit more about. But the goal is to use skills to bring a person's distress down to a point where they can make more rational and logical decisions. The next core theory of DBT is Zen practice. So some of the tenets of Zen practice in DBT are that we must see the world as it really is, that suffering is unavoidable, that avoidance of suffering leads to worse suffering, and that insatiable desires cause suffering. All things are perfect as they are, all people have inherent wisdom, and we must practice compassion towards ourselves and others. So it's sort of clear when you look at the difference between the Zen practice and the cognitive, the behavioral science. The Zen practice really is encouraging clients to be more accepting of themselves, to accept the world around them, to see it as it really is, and to accept pain, but to sort of decrease the fight against pain, to decrease suffering. So here are some of the ways in which DBT has translated Zen practice. Obviously, one of the main ways is the core mindfulness module of DBT, where we teach mindfulness skills. Mindfulness skills are considered sort of at the core of all of the other DBT skills. Another place is in radical acceptance, which is within the distress tolerance module. And then finally in validation. So one of the things that we talk about in DBT under mindfulness is states of mind. So we're encouraging clients to actually tap into their inner wisdom. Most often clients who suffer from emotion dysregulation and substance use lose trust in themselves. And what we find is that people tend to vacillate between the two sides. So emotion mind on the left side is just sort of functions under the pleasure principle, almost like just acting on whatever's happening in the moment, viewing the world through an emotional lens, not really taking into account the impact of behaviors or the long-term impact of choices that we make. The other side of it, which is just as unhelpful, is only looking at the logical and sort of oversimplifying problems. So sometimes we see it in people saying, well, next time I'm just going to do better, right? So what we're trying to teach is to teach people to learn to trust themselves. And so we'll often ask clients to tap into their wise mind, because what we believe is that everybody has an inherent wisdom. And what wise mind is the synthesis of the emotion mind and the reasonable mind together, taking both into account. And that requires, that is a mindfulness skill. The next is radical acceptance. So that's a skill that we use when we can't keep painful events or emotions from coming our way. Oftentimes things happen that are just horrible and there's nothing we can do about them. But oftentimes fighting against them actually creates more pain. So when we say radical, we mean all the way, completely and totally. And it is accepting in your mind, your heart, and your body. And it's when we stop fighting reality and let go of bitterness, that's when we can actually radically accept that something's happened. So the diagram on the right side of the page, I think, is a helpful way of thinking about radical acceptance. Pain is inevitable, right? And it's at the center of the diagram, but it's all of the stuff that we add to pain that makes it so big and unmanageable. And so with radical acceptance, we're really trying to mindfully look at what is the actual pain and how do we separate the pain from all of the stuff that we're adding to it. So finally, validation. So what is validation? Validation is a really important skill that we teach clients to use for themselves. We use it as clinicians for our clients, and we teach family members also how to use validation, because validation is the key to helping people with emotion dysregulation learn to improve their relationships, to learn to regulate their own emotions. And it helps us build a therapeutic relationship in order to be able to to help clients make the change. So validation is finding the kernel of truth or verifying the facts of a situation. So it acknowledges that emotions, thoughts, and behaviors have causes and are understandable. So if we're using substance use as an example, how do we find what is valid about a person's substance use? What our clients most often hear is what's invalid about it. So, if you only loved your family enough, you wouldn't use, or if you had enough self-will, you would just stop using. But what we can validate is this substance really has a hold on you. And you've tried time and time again to stop, but you haven't been able to stop. That is true. It doesn't excuse the consequences of the behavior, but it starts the person, whoever they're communicating with, on a common ground, so that we can actually move to a place of change. So we push the clients to validate themselves, to validate others, but we as clinicians are also looking for what is actually understandable and true about a client's behavior or a reaction to a situation. So if somebody were to storm out of a group, for example, that may not be an effective behavior, but we can understand that maybe the group topic triggered a memory from childhood that was really upsetting. And we can understand why that memory might be so upsetting. Doesn't mean that the behavior was effective, but we can understand why it happened. And so we're starting on a common ground. So the last core theory in DBT is dialectical philosophy. These are the dialectical principles in DBT: that people and behaviors are holistic, connected, and in relationship. That everything that is in relationship is complex, oppositional, and in polarity. That change is continual, and that change is transactional. So the idea, the basic dialectical principle is that everything, which is the thesis, has an antithesis, and together those make a synthesis. So these are some of the core dialectics in DBT. And the idea is, the best way that I think of dialectics is thinking about switching from either or to both and. So anything that you would say, we're trying to do this or that, if you add and instead, you're looking at it more dialectically. So rather than looking at making people change versus accepting them, we're wanting to both balance change and acceptance. We want to help people eliminate their painful emotions while also accepting their painful emotions. Those are some of the core dialectics. Some other dialectics that we really try to maintain balance between throughout treatment is enhancing people's skills while accepting people for the skills that they already have. solving problems versus accepting that problems exist and may take longer to solve, regulating emotions versus tolerating emotions, and then self-efficacy versus help-seeking. So DBT has been adapted specifically in the latest revision of the DBT Skills Training Manual to specifically address substance use disorders. So this is sort of the specific type of treatment that we tend to focus on in our program because the clients that we work with do most often have a primary substance use disorder. But our clients most often also have other target behaviors that they're working on at the same time. So what we try to do is to look at addiction as one of many target behaviors, and we try to sort of broaden the idea of addiction. So scientists have traditionally confined their use of the term addiction to substances that clearly foster physical dependence, but new knowledge suggests that as far as the brain is concerned, a reward is a reward, regardless of whether it comes from a chemical or an experience. So self-harm is the best example that I have, in which a behavior that's not a drug that a person takes has a clearly is clearly impactful on a person's brain functioning, tends to be repetitive. People tend to get dependent on the behavior to regulate their emotions. And people often try to stop but can't. So there are a lot of similarities that, if you look at the brain science, tend to go back to the dopamine track of the brain. So once people get addicted, the pleasure of the addictive behavior may go down, but the urge to engage in the addictive behavior will not only increase, but will intensify. So what we find is that most often the addictive behavior starts with pleasure seeking. But even though the pleasure may not continue past the first few times, the urge to engage continues to increase and intensify. And some people say that when they engage in addictive behaviors, they feel normal again. In these cases, a behavior that may have started with positive reinforcement in that it gives pleasure comes to be maintained by negative reinforcement in that it stops unbearable distress. So for most of our clients, this is the case. They're no longer using substances or engaging in behaviors for pleasure. They're actually using the behaviors to stop feeling so distressed and uncomfortable. So this is how we look at substance use disorders in general, is that they really aren't that different from a lot of other target behaviors. And at the same time, they do also hold a specific place in treatment, in the sense that there are different ways of going about treatment. There's a more biological component to some parts of it. We have to take, the sort of medical risks into account. But as far as a behavioral treatment is concerned, we look at it as a reinforcer, just like any other reinforcer. So there are some specific adaptations for DBT, DBT adaptations for substance use disorders. What I'll mention, just because I won't go into it so much into this presentation, is that the other 4 modules of DBT, emotion regulation, distress tolerance, mindfulness, and interpersonal effectiveness, we use all of those in our programs. We particularly use a lot of distress tolerance skills during the beginning portion of treatment when clients are having cravings, having withdrawal symptoms, are having a hard time staying motivated for treatment. We often help clients get through those moments using some of the distress tolerance skills. And so actually with the newest adaptation, the substance use disorder skills all fall under distress tolerance, and they're titled When the Crisis is Addiction. And so those are sort of specific skills that are designed to help with addiction, but all of the DBT skills in general are considered a core part of DBT for substance use disorders. So one of the main things that we teach in DBT for substance use disorders is dialectical abstinence. So the concept of dialectical abstinence is, it takes into account dialectical philosophy and looks at sort of the 2 most common approaches to substance abuse treatment. So on one hand, we have abstinence-only models that would take into account 12-step models, where people are saying the goal, what we want to do is have people stop using substances forever, make a commitment to stopping and not use. The harm reduction model is the idea that people make goals and try to work towards reducing their substance use or reducing the harm that it creates, with the goal of overall improvement in functioning, but not so much looking at whether the person is completely abstinent from the substance or not. So the way that we look at this in DBT is we try to synthesize the two. So the idea is that there's wisdom in both. So the wisdom in the abstinence only model, and what we find through research, is that people who follow an abstinence only program tend to have longer periods of sobriety. It's also more straightforward to measure sort of whether they're succeeding or not in the program. The downside is that with abstinence only treatment, people's relapses tend to be more severe, last longer, and it takes them longer to get back on track. So for harm reduction, there's also some wisdom there, which is that we're looking at the bigger picture and thinking, okay, well, if I was drinking 4 drinks a night and now I'm drinking 2, that's an improvement. And there's something to be said there, because research does bear out that overall, people's relapses tend to be, or people's use tends to decrease over time. They don't tend to go off track for as long, and they get back on track. The problem with harm reduction models is that oftentimes people cannot maintain the goals that they set for themselves, and tend to go quickly back to overuse. So dialectical abstinence looks at it from a sort of dual perspective. The idea is that we take the wisdom of the abstinence model, and clients are asked to commit to 100% abstinence. That's what we require in our program, and that's part of the DBT model. So the idea is you sort of shut the door to substance use. You have to make a commitment to staying off the substance. At the same time, what we want people to do is to use the wisdom of harm reduction to help prepare for the potential of a lapse or for the potential of cravings, and not to keep themselves only committed to abstinence while ignoring the fact that urges may come up in the future. So what we do in our program is we come up with a dialectical abstinence plan, meaning that clients are, on the first half, making a commitment to abstinence and figuring out all the ways in which they'll stay committed to abstinence. And then in the second half, figuring out what to do if that commitment wavers or if they fall off track with that plan. Another skill that we teach in DBT for substance use disorders is the path to clear mind. So clear mind is the synthesis between clean mind and addict mind. So addict mind is usually where people come into the program. They've been using for a while. Their mind is sort of set on how to get the substance, using the substance, ways in which they can, get out of trouble, things like that, and sort of building their life around the addiction. Clean mind is sort of the opposite pole, which is when a person has been out of addict mind and sort of loses track of what the potential of that could be. When people are in clean mind, they tend to oversimplify, sort of like the reasonable mind aspect of the wise mind dialectic. They tend to oversimplify the problem. So might think that they can just go back to substance use in a controlled manner, for example, or can be around other people that are using substances. That now that they've been in treatment, once they get out, they're ready to just, go back to their life the way that it was. So we would call that clean mind thinking. It's thinking about substance recovery with a naivete that doesn't take into account that addict mind is sort of right around the corner. So clear mind is the goal that we're working towards, which is the synthesis of both. It's sort of being proud of the accomplishments of being able to maintain some sobriety, while also taking into account that addict mind is a part of your mind, and that you have to plan and take seriously the fact that that relapse is possible, or that substance use may be tempting at another time in the future. So what we often see in our programs is that people pretty quickly shift to clean mind, and often, again, sort of undervalue the importance of keeping themselves safe from addict mind, and can quickly slip into addict mind because they haven't sort of prepared enough for that. So clear mind is where we want people to get, and they have to go through clean mind first, obviously, but we want to keep them in touch with both sides. So finally, some of the things that we're looking at in teaching some of the other general skills is helping people decrease their urges and cravings. So in our programs, we sort of welcome urges and cravings. What I usually teach clients on their first or second day is that if you're not having urges or cravings, then something's wrong, because otherwise you wouldn't be in residential substance use treatment. So noticing, self-monitoring urges and cravings is actually the first step. We want people to notice when they're having urges and cravings, and we want them to start using skills in place of the substance use. So what's interesting about urges is they actually don't predict substance use. The problem is when we let urges stay around for too long and don't do anything about them, that it actually leads to substance use. So we're asking people to mindfully self-monitor urges. We want to normalize the presence of urges. So we teach clients about urges. We normalize urges pretty early on, and we explain that anybody that is dealing with getting off of a substance is likely to have urges. So we ask clients to sort of look for them, even if it's a passing thought. That's something to look at, something to bring up in therapy, and something to get support around. And if somebody's having urges in the program, what we encourage them to do is to seek coaching immediately. What coaching is where in the moment somebody can come to a staff member and say, hey, I'm having an urge at a 2 out of 5 to use a substance. Is there a skill I can use? And at that point, the staff would offer a suggestion of a skill that might relate to the level of the urge that the client's experiencing. So I had previously mentioned the tip skills. Another skill might be a distract skill, right? So helping a client figure out something to do that's distracting to help them get through the urge. So we're not asking them to pretend like the urge isn't there, but we're helping them ride out the urge with less discomfort so that they can find that the urge actually sort of peaks on its own and then comes down on its own when we don't intervene with substance use. So what substance use does is it actually reinforces the urge, which is why urges increase over time as substance use continues. The next part is we want to help clients label urges and detach from them. So this is a mindfulness skill. It's the observe and describe skill. We want them to just notice the urges and feel them in their body. And we help clients do this by teaching them mindfulness skills and helping them understand that when you can detach from the urges and label them non-judgmentally, they're actually easier to deal with, and that we all have urges, that urges are a normal part of life, but that urges don't always have to be acted on. And then the last thing that we do is we use imagery to help clients ride through urges. So urge surfing is a common technique that we use in which clients actually envision a wave and watch as their urges rise and fall. And people can find incredible success in being able to find that their urge actually peaked, felt almost unbearable, and then came down on its own. And we sort of developed this as a model for the future in which people can realize that if they have an urge, it's normal. They don't have to be afraid of it. They also don't have to act on it, and that it will pass on its own. And the same thing relates to any urges. So we want people to look at their self-harm urges in the same way. We want people to look at their urges to lash out in the same way. So all of that sort of falls under the same category. Just looking at the time. Okay. Oh. Okay. So I guess now I will take questions. Okay. Do we have any questions? If you guys have questions, you can put them in the chat box. Oh, okay. We can give a couple of minutes if people have questions. Okay, so somebody asked what the tip skill is. So the tip skill falls under distress tolerance. So if you have the workbook, the manual. It falls under distress tolerance, and it stands for temperature, intense exercise, paced breathing, and paired muscle relaxation. So these are the skills that we often teach first because they're the skills that don't require any thinking per se. These are the skills that we ask clients to use when they're at like a 8, 9, or 10 out of 10 on their SUD scale. So temperature is changing the temperature actually of your upper face, so that initiates the mammalian dive reflex, decreases your heart rate, and gets the parasympathetic nervous system going. So what we often do in our program is either encourage people to take really cold showers, or otherwise we set up an ice bath with ice and cold water and have them dip their faces in ice. The important part about this is to get your face in the water to decrease the level of anxiety and distress. Intense exercise is just that. So doing something intense, not just like walking, but doing sprints, for example, or doing jumping jacks, and that we often see that gets a person's dysregulation down a little bit. And then finally, paired muscle relaxation, where you tense and release muscles, and often that's done with breathing, with paced breathing, in which people sort of sit down and count their breaths. There are many different ways to do it. 4-7-9 is the way that we do it. So inhale for 4, hold for 7, exhale for 9. But there's all kinds of different ways to do it. So that's what the tip skills are. Okay, next question is, I work as a therapist with eating disorder populations who often also have substance use behaviors. What are some ways that as clinicians we can help our clients maintain motivation? So it's a great question. I mean, I think it's a big question, and I think it sort of depends. So what we find to be most motivating, because a lot of our clients are also struggle with similar types of behaviors, is when we can explain what the underlying problem is. So we do a lot of education around the biosocial theory and explain how the biosocial theory actually relates to their behaviors. So what our clients often struggle with is the idea of this sort of whack-a-mole. So they may have done eating disorder treatment, and once they've gotten rid of that behavior, now a substance use behavior may have come around. So explaining that those are all attempts to regulate emotions can be really helpful, and also helps with motivation. So the other thing that I do is there are outcome studies that I keep, that I like to share with clients, where I'll show clients sort of what the outcomes are for DBT and the long-term outcomes for BPD, which are all really promising. And so explain to clients that if we can do this treatment, if we can get you through this, if we can teach you the skills, you're actually looking at the potential of having a lot of relief from your symptoms and a potential cure for your illness. So any other questions? Okay. I think in that case, we will wrap up. Thank you, everybody, and stay tuned for the 2020 community education events. Thanks, everyone. Thanks, guys.